Hello friends, I'm Dr. Jeevram. I'm going to discuss the management of snakebite. General measures for snakebite management. Clean the site well with cetrimide plus chlorhexidine or hydrogen peroxide or detergent and remove the fangs if any. Update tetanus immunization. Do not use a tourniquet. Apply adequate local pressure on the bite, thumb or index finger. Incision and suction. Using an appropriate suction cap, not your mouth, is useful in the first 30 minutes. Immobilize the affected extremity with a splint. Single excision with 1 hour through the tongue punctures can remove most of the venom. If in shock, treat aggressively with saline infusions, blood transfusion and vasopressor agents. Hospital care for snakebite. Treatment of shock, respiratory arrest. Treat shock if present. Paralysis of respiratory muscles can last for days and requires intubation and mechanical ventilation or manual ventilation with a mask or endotracheal tube and bag. The release of staff and or relatives until respiratory function returns. Attention to careful securing of endotracheal tube is important. An alternative is to perform an elective tracheostomy. Antivenom. If there are systemic signs or severe local signs, swelling of more than half of the limb or severe necrosis, give antivenom if available. Prepare IM injection epinephrine and IV injection chlorpheniramine and be ready if allergic reaction occurs. Give monovalent antivenom if the species of snake is known. Give polyvalent antivenom if the species is not known. Follow the directions given on the antivenom preparation. Dilute the antivenom in 2 to 3 volumes of 0.9% saline and give intravenously over 1 hour. Give more slowly initially and monitor closely for anaphylaxis or other serious adverse reactions. If itching, urticarial rash, restlessness, fever, cough or difficult breathing develop, then stop antivenom and give epinephrine 0.01 ml per kg of 1 per 1000 or 0.1 ml per kg of 1 per 10,000 solution subcutaneously and IM or IV subcutaneously chlorpheniramine to 50 micrograms per kg. When the patient is stable, restart antivenom infusion slowly. More antivenom should be given after 6 hours if there is a recurrence of blood incoagulability or after 1 to 2 hours if the patient is continuing to bleed briskly or has deteriorating neurotoxic or cardiovascular signs. Blood transfusion should not be required if antivenom is given. Response of abnormal neurological signs to antivenom is more variable and depends on type of venom. If there is no response to antivenom infusion, this should be repeated. Anticholinesterase can reverse neurological signs in some species of snake. In minimal symptoms, 1 to 4 vials of ASV should be given. In moderate symptoms, 5 to 9 vials of ASV should be given. In severe symptoms, 10 to 15 vials of ASV should be given. Surgical treatment of snakebite. Seek surgical opinion if there is a severe swelling in a limb, it's pulseless or painful, or there is a local necrosis. Surgical care will include excision of dead tissue from wound, incision of facial membranes to relieve pressure in limb compartments if necessary, skin grafting if extensive necrosis, tracheostomy or endotracheal intubation if paralysis of muscles involved in swallowing occurs. Supportive treatment of snakebite. Give fluids orally or by NG tube according to daily requirements. Keep a close record of fluid intake and output. Provide adequate pain relief. Elevate limb if swollen. Give anti-tetanus prophylaxis. Antibiotic treatment is not required unless there is a tissue necrosis at wound site. Monitor very closely immediately after admission, then hourly for at least 24 hours as envenoming can develop rapidly.